everyone. Welcome to Research MD. So we got a great morning report case presentation today. So let's start.
A 75-year-old male presented to the emergency room for evaluation of right flank pain.
75-year-old
Male presented to the emergency room for evaluation of right flank pain.
Okay, right flank pain. Okay. So let's talk about every situation when I get a call or somebody call me or if I go to the emergency room, what's the first thing I always kind of rule out? Is there an emergency I'm missing right here? Okay, so what are the emergency? Because you can take your 2-hour H&P and then you find out about the emergency, the patient probably will be dead by that time, right? So we need to, the first thing is so what are the emergencies in right flank pain? Somebody can tell me what are the emergencies that could kill the patient if you don't act on it?
Maybe
Is there let's say the retroperitoneal hemorrhage, right? That's like an emergency. People kind of die. Abdominal aortic aneurysm rupture, that can present as sometimes, And then the other thing is any kind of renal infarction, which you need to kind of act on it right away. Very, very important, okay? So let's talk about our differential diagnosis of right flank pain, right? So let's look at the renal causes. So what are the number one renal causes of the
renal stones?
We can have stone. What else? You can have renal infarction,
Yes.
right? You can have stricture, renal cyst.
Yes.
Okay. So we'll write stone, right? Or any kind of mass, cyst, infarction. Any of this kind of related to the kidney, that can cause the right flank pain, okay? Now, let's look at the other category I usually put is the infectious causes. All right, let's talk about the infectious causes. What are some of the infectious causes we can have?
Perinephric abscess.
Okay, more let's look at the common things first.
Okay.
What are the pyelonephritis, right? No, they're not going to have abscess all the time. So let's say pyelo, right?
Okay.
Pyelo, and what else? Any kind of abscess,
Yes.
right? Let's put an abscess right here. Abscess related to kidney. What else? What else can cause? Psoas abscess also,
Right.
the other thing, okay? So let's say psoas abscess. And anything kind of related to the spinal cord or the vertebrae, right? Discitis, osteomyelitis, right? Epidural abscess. So we'll say discitis, right? Osteomyelitis, okay? And the other thing, a lot of times I've seen these people, they come in the flank pain, people don't examine, and they found out the patient might have, varicella zoster infection, the distribution and all that too. So be careful about that too. Put it at the last. Not very common, but severe pain. It's very important to, rob the patient and kind of examine and all that too. Now, what are the vascular causes? Let's look at the vascular causes. What are the vascular causes? Somebody tell me.
Abdominal aortic aneurysm.
Abdominal aortic is a catastrophe, right? Abdominal aortic aneurysm, rupture, or expanding. Doesn't have to be a rupture, maybe an expanding. What else? What are the vascular? Renal infarction, right? Renal embolism, renal infarction. Usually, I see it, most of the time I see the patient have septic embolism, right? And then infective endocarditis, then you see splenic infarction, you got renal infarction, those kind of things, and also you have to be very careful, right? And then what else? Any kind of, we talk about the vascular, what are the other things? Any kind of trauma, right? Let's talk about trauma. Spasm or any kind of injury, right? And also, what are the other major categories? Females, right? I think the other thing I'll just put females, a lot of organs in that area. What are the common, ectopic pregnancy? Very good, excellent. Ectopic pregnancy, we have to worry. And then all of this endometriosis, ovarian cyst, right? Any kind of malignancy also. All right, so we talk about like this broad differential kind of look at it, like what are the causes of right flank pain? We talked about it, right? So now tell me what's going on with the patient. What is the patient, describe the patient's
Yes.
symptoms.
So patient presented with sudden onset. The pain was sudden in onset, which was on
Okay.
the right.
So
flank.
what are the things, what are the, some situation you can have sudden flank pain? What are the situation? Any of the emergencies we talk about is sudden. It doesn't give
Right.
you, right? Abdominal aortic aneurysm rupture. What are the most common cause of like sudden onset? Maybe like kidney stones and also
Kidney
could be
stone.
sudden onset, right? If it is an infection, you got a little bit of time kind of going in and all those kind of thing, right? Okay, what else?
So the pain, which was non-radiating to his groin and his back.
Okay, so
The-
pain is kind of radiate into the groin. So what does that tell us? What does that tell us?
It's probably it can be renal stones.
Yeah, most likely. Like, I mean,
Right.
very the common description. Okay, what else?
And the pain was severe and sharp in nature.
Okay, sharp pain.
He was nauseous, but there was no episode of
Okay, if
vomiting.
you look at it, when you look at let's look at what is the most common cause of flank pain is what? Kidney stones, right? So we need to know, it's like, what is the pain type? Usually like a stabbing type of pain, right? A knife like that kind of thing, right? And the pain usually depends upon where the stone is, the pain can kind of radiate to the groin. Which type of stones usually the pain radiate to the groin? Let's say like the pain, I think it's good to connect where the stone is and the symptoms also. Let's say somebody have stones in the renal calyx on the renal system. I mean, the kidney. Where the pain usually?
Groin.
No, wrong.
Okay.
Usually the pain when you have the distal ureter kind of thing, okay?
Okay.
So when you have, what are the other common characteristics of the pain when there is a urethral stone in the distal ureter? Can somebody tell me? They're the one that usually have urinary symptoms,
Okay.
right? Urinary urgency, increased frequency, and those kind of. Did this patient have any of that symptom?
No.
Okay, so it doesn't support that, but distal uretral, the pain kind of radiate into the groin, that could be, I mean, we have to think about a urethral stone, right, in this situation and all that. Okay, what else? It's associated with the nausea and all
Yes,
those kind of
nausea,
things,
vomiting,
right? Do we need to know there's a fever associated? Why should we know there's a fever?
If any UTIs or infections.
Any kind of like infection kind of going on and those things like, but was there a fever or anything?
No.
Okay, so any of those kind of doesn't come up here. Okay, and now let's go to the past medical history.
Yes.
What are the things in the past medical history? Before we go into past medical history, why should we need about the past medical history? Like right now, let's stop right here. What's our differential diagnosis? What is our, what did they say? Like 95% time you get a history and then you can come with a diagnosis. So what is our diagnosis at this point? Based on what do we know? Can we say like probably like kidney stone?
Right.
Yeah.
Right? Most
Yeah.
common, we can always, anytime if you don't understand, pick the most common cause, okay?
Yes.
So in the past medical history, what kind of past medical history we need to know? When somebody with a flank pain. Let's talk about somebody with a flank pain. What are the things we need to know in the past medical history?
If the family.
Because we already talk about abdominal aortic aneurysm causes it, right? We need to know that, right? If there's like history of abdominal aortic aneurysm. If you have, you got like the, what about?
Polycystic kidney disease.
Polycystic kidney disease because kind of cyst
Right,
formation. We know that can cause like pain, but usually have like hematuria,
Right,
those
right.
kind of things. When this patient didn't have any hematuria, he wasn't complaining anything
No.
about it. Okay, do we need to know about inflammatory bowel disease?
Yes.
Right, that's very important. That can they cause stones?
Yes, calcium
Okay.
oxalate.
Well, how does how does it cause like stone?
Okay, so basically what happens is like calcium. So when there is a
Louder. Speak up louder.
So when there is a malabsorption of bile salts because of IBD,
Okay.
so so there is a fat malabsorption.
Okay.
So that eventually leads to fatty acids in the lumen.
Okay.
So where the fatty acid it combines with the calcium and forms calcium fatty acid complex.
Okay.
So the oxalate is left over, and the oxalate eventually gets into the systemic circulation and eventually to the kidney,
Okay.
where it combines with the calcium. It forms calcium oxalate stones.
Okay, very good. So that is like calcium oxalate stone. So it's important to have inflammatory bowel disease like we need to. Hyperparathyroidism, do we need to know the history of hyperparathyroidism? That can also cause
Yes.
like kind of stones and all that, right? What about small bowel resection? Those kind of things we need to know. Frequent urinary tract infection, why should we worry? Frequent urinary tract infection. Can they cause like renal stones?
Yes.
Right?
Yes.
They can have pyelonephritis, can it cause like abscess, and those kind of things. So tell me, what is this patient past medical history?
The patient had calcium nephrolithiasis,
You got nephrolithiasis.
history of hyperlipidemia, and kidney stones.
And hyperlipidemia. Okay. So patient now, our diagnosis kind of again making it stronger. We said sudden onset of pain, radiating to the groin, now previous history of nephrolithiasis, and now we have like a little bit more clear picture. Right? This has most likely this come a renal stone, right? Everybody agree with that?
Yes.
Okay. All right. So we talk about past medical history, talk about the family history next. Why is it the family history is important?
Like few stones,
Somebody tell me, why is it family history?
like cystine stones and all.
Cystine stones, like some, autosomal dominant, like genetic component also stone, like cystine stone, that's why. Can you tell me about any family history of that's important for, even, of course, we need to know about the malignancy, those kind of things also, right? Family history is important. Medication, right?
Yes.
So, talk about medication. What are the medications why do we need to worry about medication? Can anybody kind of link an emergency and a medication? We already said like two emergencies, right? What is the one I said, like three most important? We need to rule out abdominal aortic aneurysm. We need to rule out retroperitoneal hemorrhage. We need to rule out renal infarction. So which medication we need to be very careful about, and most important, anticoagulation. Okay, somebody is on anticoagulation, come with flank pain, always kind of retroperitoneal hemorrhage is an emergency to roll out. Is the patient taking an anticoagulation?
No.
No. Okay, what medicine the patient is
Patient is on rosuvastatin and tamsulosin.
Tamsulosin?
And rosuvastatin.
Okay, that's an alpha blocker. I don't know. This is a male patient, right? If it's taken for prostate or if maybe because of the kidney stone, I don't know. I'm thinking most likely patient had like a prostate problem. That's what taken. Agree?
Yes.
All right, so we talk about the medication. Why is it social history is important? Right, smoking? I guess we can say smoking kind of related to malignancy, right? That could be like, but that can also cause alcohol. Why is it alcohol history is important in a patient with a stone? Anybody can kind of link? All of this make a great doctor if you can link a lot of things, okay? When you talk about like alcohol poisoning, that's very, very important, right? What are the ethylene glycol?
Antifreeze.
Okay, what does ethylene glycol do? Glycoxylic acid and then oxalic acid become crystal. And then you got kidney failure. When you take the urine, you can say the oxalate crystals, right?
Right.
Okay. So that is like, that's also kind of thing I think you just kind of, stone formation kind of contribute to, okay?
Yes.
And then we talk about, what about diet? Do we need to know about the diet in this patient?
Yes.
Yes.
Okay. Why is that?
Excess of meat and all can
The
cause-
patient is taking
The
excess
patient,
of-
right, we already
Right.
think our differential diagnosis, number one, kidney stones, right? If they eat like meat, like a lot of protein, that can contribute, right? So vegetarian diet is better, right?
Yes.
Fruits, vegetables and all that, drink plenty of, we need to know like what kind of work is due. Like let's say if you're like construction worker, if he's not drinking enough water, and all of this kind of contribute to it, right?
Yeah.
Okay.
Diet rich in vitamin C as well. In vitamin
Very
C,
good. We
vitamin
didn't
D.
talk about excellent point. When you talk about the medication, a lot of people, right? If you look at the vitamin store, every time I go, there's so many people out there. Everybody is consuming vitamins now. Vitamin C is like a very, very important, right? That can cause like kidney stones also. So we'll put that check there. Does this patient have any of the history of any vitamin supplement he's taking?
No, no doctor.
Okay, very important, all right. So dietary history kind of important, like and all those kind of thing, okay. So now we talk about the vital signs,
Yes.
right? Talk about the vital signs.
Patient's blood pressure was 156 by 81.
Uh-huh,
Temperature was 97.4.
uh-huh.
Pulse was 66. Respiratory rate was 18. Saturation was 98%.
98%. So it doesn't like what are we looking for? Anytime somebody have this much pain, like right, blood pressure has to go up, right? If this pain is like, what else those vital signs kind of tell me? What happens if this guy is in severe pain? What's going to happen to the heart rate? It increased, right? So I don't know how much severity. Sometimes I look at the vital signs and say, like, the heart rate like 100 and 110, and I'll make sure this guy's in very extremely severe pain and all. That's 66 kind of like, but nothing, it's not like clinically kind of significant. Now, what are the we did the vital signs, and now what are the things we have to do in examination?
Yes.
What are the things we need to do on the examination? Anybody can think? Anything like a focused examination, and the abdominal examination is very, very important, right? We need to worry about, always kind of look about, a lot of times I've seen people forget to do the examination of the back, right? And then maybe like a herpes zoster inflammation, and people automatically go and do like a CT scan. I have seen that so many times and all that. So we need to check for severe tenderness, right?
Yes.
You just go in the back so you have to look for severe tenderness. What does the severe tenderness tell us?
Pyelonephritis.
Could be pyelonephritis, okay? That would be like those kind of things you have to know. And so anything on the examination?
No, the patient
Abdominal examination is the most important thing.
Yes.
You need to look and see like there's no masses or anything kind of, if you need like a rectal examination, it's also not bad to do. Anytime you have an abdominal pain or flank pain, I think I recommend everybody do a rectal to find out what else is going on, right? You don't want to get surprises right there. Okay, so what else? What are the other things we have to do? So we did all this. So tell me so examination was completely
Yes, it was
normal.
normal.
So let's talk about the labs, right? What investigations will we order? And tell me, don't tell me all of this first. Before we order, what will be the lab work we need to do?
CBC
We need to do CBC. Why is that?
to rule out infection.
Okay, so what is the WBC?
WBC is 12.7.
12.7. So
Hemoglobin.
anytime I see this, I'll put a circle right there, right? Hemoglobin is what?
13.8.
13.8.
And platelets is 201.
201. Okay. So we did what is the next one? Do we need a BMP or CMP?
Yes.
Okay, what are the things we need to order? Why is sodium is
sodium.
important to us? Is it important to us?
Yes.
Yes.
Why? I don't know, maybe like a dehydration kind of
Yes.
picture and all that too, right? In malignancy also sometimes, SIADH, we can say what's the most common cause of hyponatremia? But sodium, what is the sodium in this patient?
138.
138, okay.
Potassium 3.5.
3.5.
Chloride 106.
Uh-huh.
Bicarb 25.
Mm-hmm.
Creat 1.3.
Uh-huh.
Create 1.3.
Oh, 1.3.
Sorry.
Okay.
And urea 15.
15?
Yeah.
Okay. So we got a little bit of, I don't know, it's 1.3, kind of a little bit of renal failure or something. Why is the metabolic acidosis important in somebody with the talking kidney stone? Type 1 renal tubular acidosis.
Yes.
Okay. Distal type 1 renal tubular acidosis with the metabolic acidosis. You're going to have what? Anion gap or non-anion gap metabolic acidosis?
Non-anion.
Non-anion, very good, excellent. Non-anion gap. So if we can link all of this kind of things together, there's a million things that we can learn from a single patient. So we did that. Any other investigations we need to do?
We also had absolute lymphocytes as 1.3 in this patient,
Yeah.
and absolute neutrophils were 10.3.
So absolute neutrophil
Neutrophil.
is high, right?
10.3. Yes.
What does that tell us? There is leukocytosis, there is an infection. What are the other investigations we need to do?
Urine analysis.
Okay, of course, urine analysis. Very, very important, right? What are the things we're looking for in this patient? Urine analysis. Let's look at what are tell me the
the
urine
labs.
analysis finding.
Yes. The appearance was cloudy. The color was yellow. Specific gravity was 1.017.
Okay, let's talk about specific gravity. Okay, what is the specific gravity?
1.017.
1.017. What is the
Yes.
normal specific gravity? 1.010. Okay, so why is it specific gravity is important? Anything? I guess the kind of dehydration kind of tell us that much, right? We can, okay, what else? What are the other things?
There was blood present in urine.
There is blood,
Yes.
okay.
WBCs were 3 to 5.
WBC is only 3 to 5,
Yes.
okay.
And RBCs were too many to count. Too numerous.
Too many RBC. The only thing we know, like there is like hematuria, and then WBC is 3 to 5 doesn't kind of support. Usually has to be greater than 5. We can say like there's an infection going on. That is what I look at it. Okay. So we did all this lab, and what other investigations we need to do? So what is our right now we're still kind of thinking what is our main top differential diagnosis? Still a kidney stone. Based on what? Somebody kind of summarize?
So
The
No? Somebody
type of-
summarize.
the history that the patient gave, that
Yeah, history
flank
prosthetic,
pain,
the flank pain, radiant to the groin,
Yes.
associated with the
Nauseous,
nausea,
vomiting.
vomiting, right?
Yes.
And then what else?
past
Family
medical
history of
history.
or past medical history of
History.
nephrolithiasis
Yes.
and all of those kind of things, right? And there is blood, which is kind of go with, renal stone, you can have blood in the urine. So what are the investigations we have to do next in this patient?
non-contrast CT.
Okay,
Non-
why did you pick non-contrast CT? Or what is the difference? Always pick, you're correct, that's the most common answer, to look at the kidney. Why can't we do like KUB? Right? Should we just go and do I don't think it's, what is the most common, we're thinking is a renal stone. What is the most common renal stone?
Calcium oxalate.
Calcium oxalate. Are they radio-opaque or radiolucent?
Radio opaque.
Radio-opaque. So most of the time, right, I think it's reasonable to start with the KUB. Do you agree? No? Why not?
Because KUB doesn't pick radio opaque.
Okay,
It's
so what
radiolucent.
radiolucent stone, we can kind of things too. So in order to catch all those kind of things, that probably the best test is what?
Non-contrast CT.
Non-contrast CT scan. And somebody so let's say non-contrast CT. Okay? And what is the sensitivity and specificity of non-contrast? Let's say, somebody say hey, I don't want this. A patient come to you and say I know CT scan, how much radiation a patient get when you do a CT scan? Somebody tell me. We cannot express in numbers. That means you don't know anything about the situation, right? So when I say I'm your patient, I come to a doctor, you're ordering a CT scan, and then I ask you, how much radiation am I getting? Am I allowed to ask that question first of all?
Yes.
Right?
Yes.
I have that's my right to ask you. What are you going to say? Somebody tell me.
Some 800 X-rays equal to 800.
It's equivalent to, the way we say it's equivalent to how many X-rays, right? So what is the CT scan? How much is equivalent to?
800 X-rays.
Yeah, it's pretty high, especially in abdominal CT, you're talking 600, 700. So what are the other tests we can do, non-invasive, kind of not radiation, an ultrasound, right?
Ultrasound.
But why don't we do ultrasound? Because sensitivity and specificity not that high, okay? When you talk about non-contrast CT, the sensitivity and specificity is extremely high. You're talking 95 to 100 range, both sensitivity and specificity. When you talk about the ultrasound, I think sensitivity is what? It's kind of low, specificity is a little bit high, okay? But in those cases, if somebody want a pregnancy patient, what would you do? Non-contrast CT or abdominal ultrasound?
Abdominal.
Ultrasound.
Okay, remember, depends upon the situation, always have to think about it. So so what did the non-contrast CT show?
It showed a right mid-ureteric calculus of 6 millimeters.
6 millimeter calculi.
Yes.
What else is show?
It also had right perinephric fat stranding.
Right, perinephric stranding.
And
Okay.
also ectopic left kidney was identified at mid-pelvis.
Ectopic kidney. Okay, let's look at this. So we know there is a 6 millimeter calculi, but we need to know, why do we need to know the size? Size. Why is it size is important? 6 millimeter. What should we why should we worry about the size? Somebody tell me.
Management.
The management is very important. So anytime somebody says kidney stone, I need to know what's the size of it. So I can decide what's the step, right? So that's very important to size, right? Do we need to know the location?
Yes.
Right?
Yes.
It's kind of need to know, the management also depends upon the what type, where the stone is. It's a mid-ureter, right? Is that what you said, mid-ureter?
Yes.
Okay, 6 millimeter calculi. What is the right perinephry stranding? What is important in this patient? Perinephry, what are the differential diagnoses? Always think about infection. Okay, so it's not that a sensitive, specific kind of diagnostic tool, but it can, if you can put all these things together, there is leukocytosis, right? And is there perinephric stranding, right? I can say there is maybe an infection, pyelonephritis. Can I say that?
Yes.
Okay, so our differential diagnosis also kind of changed a little bit. Ectopic kidney, what is the significance of it? Usually remains asymptomatic, right? Can also contribute, like, have kidney stones and all those kind of things. Any other investigation anybody wanted to do? So let's go to our assessment and plan, right? So we will, we know there is leukocytosis, right? We know there is a calculi. There is no right perinephric standing. What else?
WBC 3 to 5 is normal or Cheriyath?
WBC, when you talk about, like, again, blood, that is
Right.
immature.
Right.
What did I say about when you diagnose urinary tract infection? WBC has to be greater than 5.
5.
Okay,
Right.
if it is 3 to 5, the chance of having an infection is very less. So I'm not, but anyway, I know there is perinephric standing. I know there is. So what is my number one diagnosis in this patient? What is the number one diagnosis? Somebody tell me. What's the number one diagnosis?
Renal stone.
Renal stones.
Huh? Is there like renal stone? Can we say like better than nephrolithiasis?
Yes.
Okay, nephrolithiasis, right? Can we what is the most common type of stone again?
Calcium.
Calcium oxalate, right? Calcium oxalate stone. Can we say like most likely calcium oxalate stone?
Yes.
Okay, let's say that. Most likely calcium oxalate stones. Okay, and how do we manage? Do we need to strain? Do we need to look at the stone analysis? Right? We need to know, even though that's like the most common stone, but we probably strain for stone analysis, right? Okay, so we know this is a 6 millimeter stone, right? So what are the things, somebody tell me, what are the things when you do have like a 6 millimeter stone you have to do? What kind of things? How do you manage 6 millimeter, right?
Pain relief.
What is when you look at the stone, right? If it is greater than 10 millimeter, that's you need to get a urology. If it is less than 10, you can usually watch it, give some IV fluid, then you can,
Alpha
diet.
blockers.
Huh?
Alpha blockers.
Alpha blocker, very good, excellent. So we can start with the alpha blocker. This patient is already on alpha blocker, right?
Yes.
So alpha blocker can move the kidney stone. Studies have shown that, so you should definitely start on that. Okay, next thing I will do is IV fluids, right? How much IV fluids we should give? How much, anybody know? How much volume we should give it to this patient? Around 2.5 liters. So make sure, our goal is to get this patient at least 2.5 liter, right? But before you give, how old is this patient? Always look at if it's an older patient, and then you have CHF and all those kind of things. You have to be very, very careful. So we'll just make the dietary recommendation. Do we need to consult urology in this patient?
No.
No.
We can
No.
wait.
Okay, again, when you consult somebody, what the question you always ask, what is my clinical question? And is this person is going to do anything different than I am going to do? Right? Those two questions, if I cannot answer those questions, you should not be consulting, right? So I know 6 millimeter stone, I can watch it, right? I can see, I can give some IV fluid, I can strain it, see if it's going to, I can start an alpha blocker, and if it doesn't improve, I can treat it symptomatic, and then if it doesn't improve in within 4 weeks, then I will consult urology, right? Just don't jump into. If it is greater than 10 millimeter or even grade 8 to 10 millimeter, and all that. But what is the reason we should consult urology in this patient? That's what our number 2 diagnosis. What is number 2 diagnosis? What's the number 2 diagnosis? Come on.
Pyelonephritis.
Pyelonephritis, right? We got a leukocyte. There's a complicated urinary tract infection. So we need to admit the patient in the hospital. We'll say pyelonephritis, right? So what happens when you have pyelonephritis plus urinary stone? Before that, what is the most common organism in urinary tract infection? E. coli, right?
coli.
What happened in there? There's a block and infection. Still E. coli,
Yes.
right? So we need to treat it. So I would say I would start with the IV subtraxone, right? And then urine culture, right? Let's say you did urine analysis, come back proteus. Why should we worry about? What type of stone?
Struvite
Struvite.
stone.
Struvite stone, very good, excellent. Okay, so it's just good to know. You can have like a lot more information. You can say it about which type of stone, but you also need to treat the patient, right? It's also very important. I mean, also kind of remember, I think, we'll come back to that. So the question is like, when you have pyelonephritis and then you have an infection, what is the next thing you have to do? Do we need to consult urology?
Yes.
Yes.
Yes, okay. So now I'm going to put a urology consult up here, right? We don't treat, if we don't relieve this obstruction, what's going to happen? This infection is going to get cleared? Not really. So it's very important, okay? So you do the blood culture, you start like IV subtrioxone. What are the other things? Anything else in this patient? Anything else we missed? Right? We pretty much
Treat
covered it.
symptoms.
Huh?
Need to treat symptoms.
Oh yeah, pain control, very good, excellent. Of course you have to treat the pain control, which you can write separate or you can write up here. What is the most recommended medication for like, you got pain from kidney stone? Which one do you give?
I think
IV answer, like IV Toradol, those
Right.
kind of thing, or those kind of thing, and or Tramadol, those kind of thing. Let's say like I would usually kind of start with IV Toradol. Right? Again, NSAID, you have to be careful, the renal failure also, if anything. Otherwise, if it is like, I use like IV morphine and IV Dilaudid. Okay? So what else? Anything else we forget? So it's a great topic. Remember, make sure you read about nephrolithiasis. So much thing to discuss. Thank you so much for joining us today. And if you have any questions or any comments about this management, we all can learn. Please make sure you comment under the comment section. And please subscribe to our channel. It will be extremely helpful to us. Thank you so much. Have a wonderful day.